Hello, everyone. Welcome to the webinar, Bridging Clinical Gaps and Disparities in Care with Patients with Triple Negative Breast Cancer. I'm Stephanie Walker. I'm a retired RN of 40 years and a fierce patient advocate. I would like you guys to share at all possible in the chat when you're able to today in the question and answer in the chat. Also, before the presentations get started, I would like to talk a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with a woman's cancer and provides outreach to the general public about signs and symptoms of women's cancer. Because no one should have to face treatment alone or with breast cancer, ovarian and uterine and cervical cancer, and also metastatic breast cancer. For more information about upcoming webinars, support groups, and our helpline, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. Once Shonta finishes her presentation, we'll begin to take some questions and answers. Feel free to engage via chat with comments and any questions for our presenter via chat or through the Q&A section that's located at the bottom of your screen. Remember that Shonta is unable to give specific medical advice, so please try to keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on our SHARE website soon. Now I'd like to hand over today's presentation to our speaker, Shonta Chambers, to introduce herself.
Well, good afternoon, everyone, and good morning, contingent upon where you are. I am so glad to be with you today. I'm Shonta Chambers, Executive Vice President for Health Equity Initiatives and Community Engagement for Patient Advocate Foundation. And I am ready to go ahead and jump in to today's presentation, and I am going to share my screen, and we're going to hope that everything works beautifully. So today's topic is around bridging clinical gaps and disparities in care for women living with triple negative breast cancer. And really what I want to be able to do today is elevate some of these opportunities to improve outcomes. So I want to tell you a little bit about Patient Advocate Foundation in the event that some of you here today aren't familiar with us. So Patient Advocate Foundation is a national nonprofit headquartered in Hampton, Virginia, and we have been in existence since 1996. We as an organization have really been at the nexus of addressing the non-clinical barriers to care for those individuals living with chronic and complex health conditions. We do this by the provision of direct one-to-one case management support. Our organization was really birthed out of a very tragic experience. Our founder, Nancy Davenport Enos, lost her dear friend Cheryl because her insurance company denied off-label usage of a therapy that could have potentially prolonged Cheryl's life. And from that very tragic event, Patient Advocate Foundation was birthed because Nancy vowed that no one should ever lose their life to breast cancer or any other condition because of an insurance-related decision. And so here we stand, 26 years later, still at the nexus and at the forefront, addressing various barriers to care. Our current CEO, Dr. Alan Boss, when you see here, you see this comment from Alan, because we realize that there are so many different consequences that one encounters when they are diagnosed with a chronic and complex health condition. There are so many factors that we have to think about that extend beyond the provision of clinical care. Those include things such as housing and utility and transportation and food. And so we as an organization stand committed to addressing these non-clinical barriers to care because we know that they are critical in one's ability to be able to access as well as to adhere to any type of care. Today's presentation, we're going to talk about a couple of things. So what is triple negative breast cancer? Provide an overview of racial and ethnic and even social economic disparities that contribute to disparate cancer care. What are some of the disparities in cancer clinical care? And more importantly, what are some solution-focused efforts that are underway? I want to elevate some of the myths and fears around clinical trials. And at the conclusion, what I want to make sure you walk away with are resources to support you or someone you love that may be currently on their cancer journey. So what is triple negative breast cancer? Triple negative breast cancer is invasive breast cancer that is estrogen receptor negative, progesterone receptor negative, and HER2 negative, hence the name triple negative. So triple negative breast cancer cannot respond to hormonal therapy medicines or the medicines that traditionally target the HER2 protein. As you can see here in this image, I love the way that the CDC actually talks about it. If you really think about the cancer cell actually being a house, right? And so when you think about these receptors actually being the keys to unlock potential therapies, as you can see in this third panel, for triple negative breast cancer, because none of these receptors are present, that is why it doesn't respond to the current therapies that are on the market. So who is actually at risk? Although triple negative breast cancer represents about 10% of breast cancers overall, nearly 20% of Black breast cancers are triple negative. Black women are nearly twice as likely to be diagnosed with triple negative breast cancer. And keep in mind that death from breast cancer overall is 40% higher than in our white counterparts. So it is critically important that we engage in early detection screening activities. So who's at risk? Black women, of course, women who are under 40, but also women who have a BRCA1 mutation. That represents those individuals who are increased risk of being diagnosed with triple negative breast cancer. So we often hear people talk about disparities. So actually, what are disparities? So disparities are actually adverse differences in the burden of disease by either a racial or ethnic minority population or some other characteristic. And so that includes those individuals who may be living in rural areas, those individuals from sexual or gender minority populations, and those who actually live in persistent poverty. So a disparity exists when there's a recognition of an overprevalence or overpresence of a disease, any type of disease. In this case, we're talking about cancer among a very specific population. So what actual populations actually experience cancer disparities? So I want to share with you this image from the American Association for Cancer Research in their most recent Cancer Disparities Progress Report from 2022. If you see here, contingent upon what the cancer is, you begin to see which population is at greater risk to experience a disparity. So for example, when we begin to look at kidney cancer, American Indians and Alaska Native populations have an 80% higher incidence of kidney cancer. If you begin to look at other infectious agents, Asian populations have a higher incidence of cancers caused by infectious agents. Of course, Black populations have more than double the mortality rate of multiple myeloma. When we begin to look at Hispanic population, they have a more than double mortality rate of liver cancer. And so when you begin to look at the full spectrum of cancer, the disparities are not created equal based upon what the cancer type is. And as I previously shared, when we start to think about Black women and cancer, although our screening rates and our incident rates are equal to our white counterparts, unfortunately, our mortality rates are greater than our white counterparts. And there are so many things that actually contribute to that type of mortality disparity. So I want to just also point out here, other than the racial and ethnic groups that we talked about in the previous slide that experience disparities, there are also other contributing characteristics, such as low socioeconomic status. So those individuals, as I mentioned before, who may be experiencing persistent poverty, they have a greater risk of experiencing cancer-related disparities. Those individuals who are either uninsured or underinsured also have a greater risk of experiencing cancer-related disparities. And guess what? Where you live also plays a factor in terms of your risk for cancer-related disparities. Our LGBTQ plus communities also represent a greater group that has a greater potential for cancer-related disparities, as well as our elderly. And so there is no one size fit all, there's no one group. When we start to think about cancer-related disparities, there are so many populations across our country that unfortunately are at risk for these cancer health disparities. So what are some of these other factors that may be contributing to cancer disparities? Many of you who may be watching this webinar have probably heard people talk about the social determinants of health. Well, what are the actual social determinants of health? So the social determinants of health are those cultural, societal, environmental factors that influence our health. And in many cases, they actually perpetuate our health disparities. And so it is where we live, it is where we work, it is where we play, it is where we pray. And many of these are actually these adverse social conditions that are really perpetual in the environments where we live. So these social determinants of health, albeit not clinical, they have a critical and enormous impact on one's ability to be able to access care. They have an impact on one's ability to be able to adhere to care. And they also have an enormous impact on one's ability to adopt a healthy lifestyle. So as I shared in the previous slide, geography matters. So where you live is so critically important to your actual cancer care, your survivorship, and long-term optimal health. So I wanted to share with you briefly just these two quotes from two women that are considered to be great champions in this space. One is from Dr. Kamara Jones, which she reminds us that we can reduce health disparities and better connect people to high quality medical care. But if we really want to make a difference, we need to address the social determinants of health and equity that protect some people while pushing others off the cliff. Well, what does that really mean? So going back to the previous slide, we talked about the social determinants of health and we talk about geography. We know that there are populations that live in substandard housing communities. We know that there are people in this country that are having to travel hours and hours to actually get to healthcare. We know that there are many people living from paycheck to paycheck and they're either working in a low wage earning job. These are all of these determinants that push people closer to falling off what she describes as the healthcare cliff. We know that these determinants are not equal opportunities employers. And we also know that it's historic policies that have actually perpetuated what we see experiencing. Some of these policies include things such as redlining. Some of these policies go back as far as the Fair Housing Act. Some of these even go back as far as the Hill-Burton Act, which really set the standards for where hospitals would be erected. And of course, that meant that they had to be erected in communities that had a high per capita income. And many of you know that that meant that these hospitals or health systems were not erected in communities of color. So what we're seeing play out in terms of some of these disparities of health, they really have a policy underpinning. And as we think about our path forward, we must realize that it is also going to take some additional and new policies to help impact health disparities in a very sustainable and deliberate way. Another quote comes from Dr. Olapati. Unfortunately, the healthcare system is finally now reckoning with the general inattention to diseases that affect certain populations. Again, the reality that certain population groups experience disparities around some conditions. Society has fragmented us into healthcare haves and have-nots. Again, these are the social determinants of health that are playing out in terms of recognizing where we have access, where we can get care, and who can actually get care based upon these other contributing determinants. So what are some of these barriers and gaps to clinical care? And more importantly, what are some solutions? What I want to do is bring to your attention some work that began last year, and I had the pleasure of co-chairing this Elevating Cancer Equity Work Group with Dr. Robert Wynn at the University of Virginia Cancer Center. And the initial research for this work began with the survey that was actually conducted by the American Cancer Society to really look at patients, and caregivers, and really understand their perception of bias in terms of care. And we also wanted to, in this body of work, what they also wanted to explore is if oncologists actually recognize potential bias in care delivery specific to cancer. And so these are just some of those preliminary findings from that actual survey. And so the very first question, and I hope you can see it, but these slides should be available. Did you or your loved one ever experience a situation where questions were not answered in a way that was easy to understand by the oncologist or the care team? And 30% of the respondents actually in this survey said yes. So blue represents experience, and orange. I'm sorry. So you see the breakdown here by whites, by patients and caregivers, and African Americans by patient and caregivers, and also by Hispanics. And so when you see this, 30% of individuals said, hey, when I asked the question, the way that it was responded to wasn't really clear to me. So when we're talking about something as serious as cancer, when patients and or their caregivers are saying, hey, I'm posing a question, but I don't really walk away with a clear understanding, that lack of understanding has a great contribution to how one responds to and adheres to care. Another one that I want to pull from here is the second question. Did you ever feel that you or your loved one's oncologist or cancer team made assumptions about you or your loved one because of your financial circumstances? And as you can see, blue represents those who say yes, they actually did experience that, as well as orange saying less than one actually responded to that. And I apologize, I may have misinterpreted this, but what we're saying is 25% of those who responded to this question actually say, yes, I truly feel like my healthcare provider made some assumptions about how they talked about care based upon my financial circumstance. Now, keep in mind, many healthcare providers don't know at the point of interaction what your financial situation is. So when we think about these assumptions, these assumptions may be being made not only on financial circumstances, but they may be being made based upon how that person looks that is sitting across from that healthcare provider. So as a result of just this survey of work, the American Cancer Society Cancer Action Network, the National Comprehensive Cancer Network, and the National Minority Quality Forum actually stood up what we call the Elevated Cancer Equity Initiative. And what they actually did was they brought together a group of stakeholders to really look at this survey, to really understand what are some of the root causes of these disparities as it relates to access to guideline concurrent care, and more importantly, to develop some actionable short and long-term policy and practice change recommendations. Because what the survey told us is that in an environment where a healthcare team should be adhering to guideline concurrent care, patients were responding that they felt like that there were other factors that were coming into play, hindering the clinical care that they were actually receiving. And so as a part of this work, what this Elevating Cancer Work Group actually proposed was actually this health equity report card. This health equity report card is really designed to put into place some measures that would require providers and health systems to really assess themselves against some very specific health equity related measures in 4 categories. They were around community engagement, accessibility of care, and the social determinants of health. Again, it's the realization that one's ability to adhere and be able to access care is not just driven by the clinical encounter, but by these other social determinants that exist within the context of the community where individuals live. We realized that it was critical for health systems and providers to undertake an acknowledgement of these social determinants as they begin to think about whole person care. The other one was addressing bias in care delivery, because what we heard from both patients as well as the oncologists that participated in that survey is that, yes, there is actual bias, whether it is implicit or explicit, there is bias actually in the care delivery system. And then fourth, the quality and comprehensiveness of actual care. And you can find this full set of recommendations at the link provided here. So what did we learn in terms of the survey, in terms of some of this data, in terms of some of these root causes to disparities in actually adhering to guideline concordant care? One, that is multifactorial. So there wasn't just one thing that was contributing to these disparities in the delivery of clinical care. We found that things like I mentioned, such as implicit and explicit bias in care delivery, meaning that you have providers or care team making assumptions based upon the person that was sitting across from them, whether it was based upon financial assumptions or simply race or ethnicity. There was also this dearth of representation of people of color in oncology. So there's great work that we really need to do as advocates, as schools of academia to really get more persons of color into oncology. And then there's also that research populations were really not reflective of diverse communities of patients. They were really homogenous. And so there's great opportunity here for us to diversify even the community of patients that are participating in research. And then of course, the lack of insurance and underinsurance, another one of those major factors contributing to disparities, as well as cost of care and financial burden, enormous financial burden, enormous financial toxicity, contributing to, again, the disparities in terms of, as Dr. Olipali would say, our haves and our have-nots, and also disparate access to clinical trials. We often talk about the fact that we're quick to say that, persons of color won't participate in trials, but we've also found that that is not necessarily true. Research has demonstrated that when asked by a trusted healthcare provider, that persons of color are most likely to participate in trials. And also the last piece here in terms of those root causes are those social needs and those social determinants of health, such as cost of living expenses, transportation, etc. All of these were actual factors that have been contributing to disparities. And so we wanted to identify some very tangible practice level barriers so that we can identify some practice level solutions. I'm not going to go through all of these, but I want to just highlight a couple of them. So at the practice level, meaning at the provider level, one of the things that was identified as a major barrier is patient mistrust of health and research systems due to historic and ongoing injustices. So it is so easy for us to say, oh, well, people are not participating in trials because of Tuskegee, etc. But we had to also realize that there are current injustices that people are encountering when they go to interface with our healthcare system. And we have to own and recognize the contribution of that in terms of one's ability to trust or not trust the healthcare system by which they're trying to interact. The other part in terms of a barrier in care is communication challenges. And that is just simply being able to communicate in a way that a patient can understand, not in the high level kind of clinical dialogue, but really in a way that a patient can understand, but also in a way that is meaningful to that patient and that patient's family. And one of the other barriers that we also identified was the need for patient navigators and community health workers, because we do know that there is a role for both of these entities to play as we begin to engage with patients along their cancer continuum. So one of the things I just mentioned was in terms of clinical trial participation. And And my understanding is that a majority of the participants that have actually signed up for this webinar are women of color. And one of the things that I really want to stress is that it is time for us to get involved in clinical trials. And that is critically important. And I'm going to share with you why. So first of all, when we don't get involved, then we're not represented in the emerging therapies that are actually coming out. And so I want to draw your attention to this graphic. And I'm actually going to read this because I think it's critically important. So if you're looking here at this image, between 2009 and 2019, FDA approved 81 oral anti-cancer chemotherapeutics. Based on data from 142 clinical trials, only 52% of these trials reported on race and ethnicity. And so although they reported on race and ethnicity, what is critically important is that look at the breakdown. So when you begin to actually look at clinical trial participants, 2.3% were Hispanic, 2.5% were Black, and more than 70% were actually white. So what that means is oftentimes when we're receiving care recommendation, it is based upon therapeutics that have not accounted for our genetics and our biologies. As such, we don't know if they will actually be effective. And in the space of triple negative breast cancer, it is just critically important, since we as Black women have a greater risk, it is critically important that we are present in the actual clinical trial so that we contribute to the science, the innovation, but more importantly, we position ourselves to be a part of contributing to therapies that will be most beneficial and most effective for us as Black women. So one of the things is, myths around clinical trials and why people don't participate. One of the biggest things is that people say, well, I'll be treated like a guinea pig. So these are many of the myths that still exist. If I join a clinical trial, I might get a sugar pill or a placebo instead of a real drug. Once I enroll in a clinical trial, I will not be able to change my mind. Clinical trials are dangerous because they use new practices and medicines. Being in a clinical trial will not help me. These are many of the narratives that I hear as I work with women in communities across the country. And let me just say that these myths are false. So the first one, which is around if I participate, false. Trial participants are fully informed of the risks and benefits and treated with respect and dignity. Things are not the way that they used to be. We have come light years ahead in terms of putting in provisions and safeties and protocols to protect individuals that actually participate in clinical trials. The second question is, I'll get a sugar pill or a placebo. False. Placebos are rarely used in cancer trials because the best available treatment, which is also known as standard of care, is actually used. So in cancer trials, you will receive standard of care. So you don't have to worry about this whole myth around a sugar pill or placebo. Number three, the myth was if you sign up for a trial, you can't get out of it. That is false as well. If you decide that you no longer wish to participate in a trial, you can withdraw at any time. Number four, I wanted to put this text here because I think it is critically important. And this was a question around trials not being safe. I think it's important to understand that because clinical trials are designed to answer important questions, research does have some level of risk. However, the safety of all clinical trial participants is top priority. It is top priority, and every trial participant is closely monitored by that clinical trial team on an ongoing basis. There are so many safety protocols that have to be cleared before a trial can even begin to enroll the first patient. And the last question is clinical. If I participate in a clinical trial, it won't help me. Yes, it will. If you choose to participate in a clinical trial, you have the unique opportunity to receive an investigational drug that's not available for patients outside of the trial. Patients who participate in clinical trials, you play a critical role in advancing medical science that help more people live longer and better lives. So again, the myths that we have been holding on for years, many of those myths are no longer valid. So I encourage you to really think about taking advantage of a clinical trial if one is presented to you. I wanted to make sure that I also share with you some resources to complement all of the amazing resources that SHARE provides. And so I've broken these up in a couple of categories, one being educational. So I've listed here on breastcancer.org. They have a wealth of resources around triple negative breast cancer. Also, you have the American Cancer Society and the Triple Negative Breast Cancer Foundation in the event that some of you may not be familiar with this organization. For those of you who may be thinking about a clinical trial, wants to really learn more about it, but you want truly to say, hey, who will really be honest with me about this trial experience? Where can I ask questions? I encourage you to visit Touch Black Breast Health Alliance. They launched last year this When We Trial initiative. I have a slide following this one that's going to give you a little bit more about what that is. But Touch Black Breast Health Alliance, Black Breast Alliance, excuse me, they launched this When We Trial initiative specifically to create this safe space for women of color to ask questions around clinical trials. So even some of those things that you're still holding on to as myths or still some of those apprehensions, this is a great place, a great space to go and get those questions answered. And also because I've already talked earlier about financial barriers being one of those contributing factors to disparities, I want to share with you some financial resources that are available through my organization, Patient Advocate Foundation, as well as some other administrative support that is available through PAF. Again, to all complement the amazing resources that you can receive directly from SHARE. So Touch Black Breast Cancer Alliance. A dear friend of mine, Ricky Fairley, she had just a very passionate woman. She is a breast cancer survivor herself. She has actually participated in clinical trials, and she tells her story of how actually participating in a clinical trial is actually what saved her life. And so, as I mentioned, they launched the When We Trial initiative last year, and that is really a safe space because she has this very bold goal of really wanting to advance breast cancer science for Black women. And she knows that the path to do that is really about engaging more Black women in actual clinical trials. So I encourage you at your leisure to take a look at that When We Trial. And again, really pose those questions that may be concerning you as it relates to clinical trial participation. One of the financial resources that I want to share with you is the National Financial Resource Directory. So PAF, as I mentioned, is a national organization, and we support patients with over 700 different conditions, including the full portfolio of oncology. So we support patients across all 50 states and the US territories, and we do it telephonically. And I'm gonna tell a little bit more about that. But in our years of existence, like I said, we've been around since 1996. What we've begun to do is curate all of the resources that our case management team actually taps into an online resource directory. And that is actually what I'm presenting to you here. It allows you to be able to search online for resources, whether you are uninsured or underinsured, or even if you do have insurance. It allows you to search a directory of a plethora of resources, from everything to medication assistance programs, to transportation, etc. So this is one of the resources that I wanted to make sure that you became aware of so that you can add it to your toolbox of resources. Not only do we have the National Financial Resource Directory, every tool, every resource we build comes out of our experience in engaging with patients. And so specifically about 2 or 3 years ago, we stood up a specific breast and metastatic breast cancer resource directory. And here what we've done is curated specifically resources to support those individuals who are living with breast cancer or metastatic breast cancer. Again, this is a digital, it's an online, it's a mobile optimized, it's a web-based platform where you can actually go in, answer a few questions, and the resource will populate a list of potential resources that you can actually reach out to based upon those needs that you've identified. Again, that could be everything from transportation to childcare to even scholarships. So that is another resource that I want to share with you. One of the financial resources that I want to make sure you go away with is, as an organization, Patient Advocate Foundation, we are one of few nonprofit organizations that has an OIG opinion to operate a copay relief program. Our copay relief program, as you can see here, has a listing of the different actual disease states for which we actually have a copay program. The copay program is really designed to help to reduce the financial distress that patients and their families are encountering that are living with a chronic or complex condition. Last year, we actually launched our Health Equity Fund. And what we did was we stood up that Health Equity Fund because, as I pointed out earlier, geography matters. And sometimes because people are not connected to the healthcare system in the same way, they don't always know how to connect to resources. And my philosophy is very simple, that just because someone doesn't know, that doesn't mean that they don't need. That means that we as national organizations have to augment our strategies to make sure that we're reaching those who are at most need in a way that is beneficial to them. And our Health Equity Fund is one way for us to actually do that. What we did was we've identified the 220 counties in the country that have a high social vulnerability index score, meaning that when you go back and think about those social determinants of health, these individuals have enormous social need gaps that are caused by these unaddressed social determinants. And because of that, we wanted to set aside these funds to reach those individuals in those counties. You can actually go to this website at copay.org. You can actually enter your zip code, and it will tell you if you actually live in one of the zip codes that are part of our Health Equity Fund. If you don't, have no fear. We have other copay relief programs that are not a part of the Health Equity Fund that may address your breast cancer and other things that you may have. So please know that this copay relief fund, I'm highlighting kind of here our breast cancer health equity fund, but we have a whole list of other copay programs, including a breast cancer genetic testing copay fund. So I encourage you again to take a look at this resource. And it's a very simple online application. It may take you about 7 minutes to complete the application, and you will get a notification immediately after you've completed your application if you have been approved. So I encourage you again, this is a financial resource that you can share. You can use yourself, share with your network, share with your sister friend, so that you know that there are other resources that are out there that may be available to support and assist you along your cancer journey. The one other thing that I want to talk about is our PAF, our case management program. This is really the foundation for our existence. And so our case management support is a one-to-one interaction where we actually assign a case manager to a patient or their caregiver or whoever may be contacting us on a patient's behalf to really understand what may be some of the barriers that they may be experiencing to care. And along with that case manager, we will work with that patient caregiver, or the person contacting us to really explore what are some viable solutions to those things. When I say issues, some of those things could be things like cost of living, or they may find themselves in a situation where you need to do an appeal and file an appeal and not sure how to go about the appeal process. we will work directly one-on-one with you as a patient, a caregiver, or again, whoever's calling us on that patient's behalf to help bring resolution to those things that may be impacting you. In order to be eligible for our case management program, there is no income eligibility. All it is that the person must either be in treatment, beginning treatment, or seeking a diagnosis in order to be eligible for a case management program. All of the services, all of the resources that I've shared with you are available to you at no cost at all. So if nothing else today, I want you to go away knowing that as you begin to embark upon this cancer journey, you don't have to do it alone. There are resources out there that may not be physically in your community, but when you think about them, they're no more than a phone call or a click away. And I hope that you found this information helpful.
Thank you so much, Ms. Chambers. Those are great resources. As a cancer patient, metastatic breast cancer, I've definitely gone to PAF before and gotten financial both, and also utilized your, you just mentioned it at the end.
Case management.
Case management, exactly. So we have a question here. It's a comment that says, thank you, and I understand that the scope of this great webinar focuses on the access to clinical trials. As an 11-year triple negative breast cancer thriver, I would not participate in a IST and triple negative clinical trial for early stage disease because TNBC is not one of the diseases, as a tumor are not molecularly the same. The tumors are not molecularly the same. Sorry about that. Because most clinical trials, except for patients who are BRCA positive or for early stage disease, do not look at the molecular makeup of the tumor at the onset. This could also contribute to poor clinical outcomes because I didn't know that. I'm sorry, I'm a nurse. I'm just reading the molecular makeup of the tumor. So precision medicine can be identified for specific TN tumors. How can you research and treat what you don't understand or know what is driving the tumor? Correct. That's a good one. In my opinion, any research for early stage triple negative that doesn't look at molecular makeup of the tumors at the onset has a fundamental trial design flaw. We need precision medicine for triple negative tumors because it is not a heterogeneous disease. And that came from Marquita, I believe, Ms. Bass.
And I would actually say, Marquita, you're absolutely right. And so my response to that will be thinking about the phases of the clinical trial experience, right? So even in the development. So one of the things, or one of the frequent conversations that the patient advocacy community is having, even with industry, is the importance of engaging patients, especially thrivers, in the beginning of the process. So not just about when it's time to do recruitment, so that the very specific things that you just noted in terms of, hey, these are the considerations, these are the things you need to be thinking about. Those conversations really should be happening at the beginning of the development, because again, it's like, if you think about metastatic only in one way, if you think about trial design only in one way, we're going to continue to execute in the way that we historically have been doing it. So I definitely encourage individuals, even if you don't desire to participate in actual recruitment element of a trial, make your voice known in identifying where those opportunities for me as a patient to help contribute to the development, so that we begin to develop trials that actually meet the unique needs of women of color.
We have another question here by Miss Bass. How do you get involved in the community or in the conversation? Honey, let me tell you. No, I have my take on that, but I'm gonna go ahead. It's your show. You go for
No, it's our show. So go
it.
ahead.
We're trying to get out. I'm not for sure what your diagnosis or anything like that, but to get involved with the conversation, you need to go to the source. And I say try, first of all, to become very big in advocacy in the triple negative community, if that's your realm, to triple negative. Join the group. They have a national organization. I say start there, or even start even on, I know people kind of like cringe when I say this, Facebook. I have a really good friend that's one of the moderators for the triple negative breast cancer group there. So you can start there to see where people are going or hanging out, to be able to get in contact with pharma or quote unquote industry, to be able to get your foot in the door. And I say that all the time. Ricky and I have done projects together, and she knows you need to have us at the table. And if you don't have us at your table, we'll bring our own. So with that being said, we want to be in there in the beginning. Don't ask for my input after the fact.
And also, if there is an academic medical center near you and they have a patient advisory council, knock on the door, kick on the door, do whatever you have to do to put yourself at that table as well, because oftentimes when industry does do trials, they tend to go to these larger academic medical centers, right? So I think being where they are going, even though we're trying to get them to think differently about that, but there are these patient and community advisory groups. And one of the recommendations in the Elevating Cancer Equity Report Card is that for these health systems that do have these patient and caregiver advisory group, that there be an equal power dynamic for those patients that are sitting on those patient and community advisory groups, not just there to be the checkoff box for the patient, but there's an equal power distribution in terms of that voice of that patient or caregiver that's sitting on those health systems, patient and caregiver advisory groups as well.
She says, thank you. This was awesome. Does anybody else have any questions for Ms. Chambers? If not, I have some that were pre-submitted. If you don't mind, we have a few minutes that we can go over some. And one of the first one actually on the list is the triple negative breast cancer statistics are for Black women, are not for Black women, I think it should say. What do we tell our families about it without scaring them? Oh, the statistics are for us are bad. So how do we engage our family without scaring the heck out of them?
I think just like with anything, just even with cancer in general, that we just have a very honest conversation about the importance of early detection and screening. Because just because we don't talk about it, it doesn't mean that it won't happen. And just because we talk about it, that doesn't mean that it is going to be a fatal experience for all of us or for everyone. But we have to begin to be proactive in our screening and early detection activities. Since COVID, we fell off significantly in terms of women that were actually going in for annual mammography screenings and things of that nature. We have to get back to our screening activities. It is critically important. We cannot not allow the consequences of COVID to hinder us from going forward with our screening activities. Now, the other part of that is, one of the other things we know is that our current screening guidelines begin at age 40. There's another advocacy opportunity here, because when you look at the risk for triple negative breast cancer, as our research shows, we're also talking about Black women younger than 40. So we have to begin to have these conversations with the young women in our lives around the importance of early detection, around the importance of screening. And stop taking just no and not yet for an answer. We got to be willing to knock on the door and kick the door down. There's opportunity for advocacy for us to make sure that everyone understands that the health and quality of life for Black women is important and it matters and it has to be taken as a priority. But we have to first take it as a priority for ourselves.
Thank you so much for that powerful statement. Very much a powerful statement. Also, another question is, can you explain the environmental or environment-related factors underlying increased risk of mortality for African-American women with triple-negative breast cancer?
So as I talked about earlier, geography matters, right? So there are these environmental exposures. I actually was doing some work in Chicago, and there was this community on the south side of Chicago where they actually built a landfill on top of the water line, right? So we know that there are some communities in this country where a landfill will never be built on top of a water line. But in our communities of color, we get landfills, we get plants, we get all of these other things that expose our communities to these environmental toxins. So we cannot ignore the role that the environment actually plays on one's ability to be healthy. When we begin to take our vote, these are the conversations that we need to begin to also be having with those that we elect to be empowered, because these are the individuals that are signing off on the actual erection of these plants and these landfills and all of these other things. These are also the individuals that we tend to neglect to hold responsible for what our communities look like. Yes, redlining happened. Now we're reversing redlining with gentrification, but all we're doing is taking one problem from one geography and putting it someplace else. We have to begin to raise the issues around the environment, the allocation of resources in communities of color, and really hold those who have the power and the purse strings accountable for being responsible to us as constituents in our communities.
Thank you so much. Your statements are powerful. I mean, and it's so true living in a Black community. These are the things that we have to do. We have to, people talk about going to the barber shops and the beauty shops to share all this information. We need to get out in the streets where they really go, where they play and, pray. Pray is one of them, but we still need to bring it out into the community more. What are some ways you think people can advocate for themselves and push past the provider implicit biases?
Be prepared when you go into your appointment and ask your questions. Be prepared. Don't just take everything at face value. If something is not clear to you, then say, I don't understand. That's not clear. I need you to take your time and explain that to me again. Because one of the things is, if you keep sitting there, no one's going to walk out the room and leave you there. But sometimes we have felt, don't allow, just because you may not have the right words, right? Or you may not have the right clinical description. Don't allow that to paralyze your desire to understand. I had a physician say to me when I said, what we have to begin to do is invite patients to the conversation. Yes, you may be the expert in the room in terms of the clinical, but you're the expert in the room on yourself. You're the expert in the room on what's important to you. You're the expert in the room around your quality of life and the quality of life that you desire to have. That healthcare team is there to serve you. They're there to provide for you. This has to be a collaboration, not a dictatorship. So prepare yourself. If you don't think of all the questions, then take somebody with you who can ask those questions. And remember, that person that's not the only game in town. That's not the only provider in town. So if you don't feel comfortable there, you have the power to go someplace else and ask those same questions. You
Don't
would
be
do it
afraid.
with your car. You would, if somebody told you this car repair was gonna cost 5,000, you felt like you were being bojangled, you would go someplace else. I want you to take that same energy and say, you know what? If you don't have time to be present for me, then I am going to go somewhere else, because you need a healthcare team that is going to be present for you and responsive for you. You owe that to yourself.
Someone in our chat, in our viewing here, mentioned the same thing, and I'm a firm believer of that, because I have the power of the checkbook, I have the power of my credit card. So, if I'm not happy with what you are telling me, or you're not listening to me, listen to me. And sometimes, that first time you're going, maybe you need to take somebody else with you to help take notes too, because I know, even as a healthcare provider for over 40 years, I heard the word cancer and everything else just kind of like went by the wayside, a little bit, just a little bit, not a lot. But you have to be comfortable with your care team, regardless. You have to be comfortable with your care team. Great presentation. I need to know how to research exactly where these environmental factors and landfills and water toxicities are. And they always want to put it back on the patient. I had did something in ASCO regarding obesity and with obesity and breast cancer. And it seems like everybody wants to put it back onto the patient. And and you can't do that. You know what I mean? They're the one that's putting the Kentucky Fried Chicken or the cigarette stores and stuff in our neighborhoods. We need to start standing. We want Ruth Chris up in there now. But you need to start demanding what's in your neighborhood. Help make that change. Educate yourself. Become healthier. Everybody said eat plant-based diet. You eat what you can afford, but make it as healthy as you can. So everybody can't do that all at once. So do your best to be healthy for yourself.
And if I can also add to that and to answer a question. So I took this out of my presentation, but I had this side by side in terms of the characteristics of those persons who's most likely to experience cancer disparities and the characteristics of persons who are most likely to experience food insecurity. And the characteristics are the same. So people who are living in low income neighborhood, people who are uninsured, people who are underinsured may be working low wage earning jobs. So what we're seeing play out is by the design of the absence of investment in communities of color. COVID blew that open, right? But
exactly,
we can't act like we didn't know. If you don't invest in something, how do you expect for it to thrive? If you don't invest in the infrastructure, if you don't invest in the economics, if you don't invest in the health of it, how do you expect for it to thrive? And it doesn't, and it hasn't. So the system has accomplished what the system has been designed to accomplish. Now it's an opportunity to dismantle, not disrupt, but dismantle the current base. And because, like I said, there have been perpetual historical policies that drive some of these disparities that we continue to see, whether they're housing, whether they're economic, whether they're transportation. So it is going to also require a policy solution to make things be different. So in terms of the question about where you go, the Environmental Protection Agency is probably the one entity that none of us ever think about. So the Environmental Protection Agency is one entity that you can look into because they have to approve anything that is environmental in context, including even content into your cleaners like your 409s and your Lysol and all of that. So your EPA, the Environmental Protection Agency, will be a place for you to actually start. And also their entities, there should be a state level environmental agencies that you can also begin to tap into for your respective state. So at your Department of Public Health, there's an environmental division. And if you can't get your answers there, the Environmental Protection Agency.
Thank you so much for that. There was one last question, and I'm going to kind of like defer a little bit on that one. It's asking, what are the best or recommended treatment options when cancer is still present after chemo, a mastectomy, and radiation? It's going to vary. Obviously, for triple negative, your treatments are limited. I don't want to say limited. There's always new ones coming out, but that I do know that there are a couple new ones coming out, and I think one was kind of like for HER2 positive or in HER2. That medication also has been known. I know somebody that's on it that has triple negative. So whether it was a one-time thing or not, I don't know. We can't prescribe, but everybody has to go by the same standards of care. So I suggest starting off, first of all, with your physician and asking them, what is your plan? What's next? What's next? What's next? And if you're not happy or satisfied there again, even though you started treatment and had treatment that was the same oncologist for 5-6 years or 2 or 3 years or 2 months, go get you a second opinion and try that. So with that being said,
And if I can really
go ahead.
quickly,
Yes.
Stephanie, also
Yes.
ask your therapy, your care teams, how have others fared who are on a similar therapy as what you're proposing for me?
Exactly. Because a lot of these, remember, have come out and we have not been present. And I'm very, very big with clinical trial and diversity. So please do ask. You know, there's blood pressure medicine out there. They told us we couldn't take either, but we've been taking it. That didn't work on us. So, you know, there's a lot out there. So please research that. So I want to thank you, Shonta, for the informative program. And thanks to all of you guys who showed up and was present and participated and submitted questions. I wanted to make sure that you check out SHARE's upcoming educational programs and support groups and follow us on social media as well. Please take the time, if you don't mind, to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email, as all surveys are done anonymously. Again, this concludes the webinar, and I thank you all for participating. You guys have a great day.